Good afternoon. Today we're going to discuss diabetes as part of endocrine disorders. Before we go into the HPA axis, as a reminder from pathophysiology, let's see what is diabetes, what you recall regarding diabetes and different types and the pathophysiology, even though it's part of your slides. Diabetes, if you recall, is an impairment of insulin secretion and basically it's at variables degree, depending if you have diabetes type 1 or diabetes type 2. It could also be that there is peripheral insulin resistance that leads to hyperglycemia. If you recall, there are two types of diabetes. Early symptoms are related to hyperglycemia and the osmotic effect of high glucose levels on the tissue, producing polydipsia, polyphagia, polyuria, weight loss, and blurred vision. You also recall that complications related to diabetes include vascular diseases such as peripheral vascular disease, neuropathies, as well as nephropathies, retinopathies, and as well as infectious processes being increased and higher risk for these patients. The main diagnosis is by measuring plasma glucose level, and we're going to go through the actual criteria of how to classify a patient with diabetes. There are two main categories. There are type 1 and type 2. In the first part of this video, we're going to discuss type 1 and the major complication of diabetes type 1, which is diabetes ketoacidosis. Then it would be a second part of the video discussing type 2 diabetes, treatment related to it with the hypoglycemic oral medications, as well as the non-ketotic hyperosmolar complication of diabetes type 2, even though it could occur in type 1 as well, which is the HHNK. So non-ketosis, hyperosmolar, hyperglycemic coma. Terms that also describe diabetes, we're going to be discussing different other types such as the mature onset diabetes, as well as juvenile diabetes, gestational, etc. So there's also another classification related to impaired glucose relation, glucose tolerance, or impaired a fasting glucose level. So we're going to go through all that criteria. Etiology, remember that in type 1 diabetes, there is insulin production being absent because there is an autoimmune pancreatic B cell destruction. That's the main thing. Previously called juvenile onset or insulin dependent, not anymore, because any times there is a destruction of pancreatic beta cells, such as in pancreatitis, for example, you could have type 1 diabetes. So it's not related to age anymore. In type 1 diabetes, you would see that insulin production is absent because there is an autoimmune pancreatic destruction, as I already said, and it could be also triggered by environmental exposure or genetic diseases. The destruction is subclinically. Many patients progress with diabetes and until clinical signs are evident. Um, Patients have decreased insulin concentrations until no longer can control plasma glucose level, and then they develop the symptoms. In type 1 diabetes, if it develops during childhood or adolescency, which actually is the most common presentation before age 30, even though, as I said, age is not a related factor anymore. Mainly would have higher complications. The pathogenesis, again, is destruction of the beta cells. Many patients are susceptible. They do have HLA related genes that could predispose them to diabetes. They could also have autoantigens, including the glutamine acid, decarboxylate, They could have elevation of C-peptide, which is a pro-insulin, and many other factors. Some patients could develop diabetes due to viral diseases such as Coxsackie virus, rubella virus, and cytomegalovirus, or Epstein-Barr virus, or even retrovirus, such as in patients with HIV. Diet may also be a factor. Um, Patients exposed to dairy products such as infants with cow milk or milk protein B casein, high nitrates levels in drinking water, or low vitamin D consumption could be linked as well to diabetes type 1. This is a very recent um, research study that has been conducted. Pathogenesis for both type 1 and type 2 is very, very similar. Other diseases that could produce diabetes, and this is in relationship to the axis, would be cystic fibrosis, patients that have Cushing syndrome, for example, or acromegaly, are highly at risk for diabetes, not only type 1 but also type 2. Patients that for some reason having an autoimmune disease or asthma or COPD or for example having rheumatoid arthritis, they have to be chronically exposed to glucocorticoids, beta blockers, even though we know that basically instead of hyperglycemia, patients mostly develop hypoglycemia and do mask signs and symptoms of hypoglycemia due to blunting of the adrenergic response. Patients also could have a rebound hyperglycemia as well, um, and many others. So let's talk a little bit about the axis, and um, we'll go after into details into type 1 and type 2. You know that diabetes is a metabolic disorder that is associated with dysregulation of a number of systems that we already included: cardiovascular and immune system, CNS as well. Because of this central nervous system dysfunction, in diabetes, there is an activation of the hypothalamus pituitary adrenocortical axis, which is the HPA axis, or hypothalamus hypophysis axis, uh, leading to an uncontrolled or poorly controlled diabetes. It is very well known that the effects in stress response in diabetes appears to be the result of a combination of decreased tissue sensitivity uh, to many other hormones that will impair the capacity of the axis and maintain the stability of the hippocampus, and also the expression of many genes that belong to other hormones in the axis. For example, referring to the anterior lobe, um, diabetes will activate, or the lack of insulin will activate or influence the enhancement of production of adrenocortical hormone, which is ACTH, for the increase of cortisol or glucocorticoids, leading to hyperglycemia. Another example is the activation of T3 and T4 for the thyroid, producing a catecholamine response as well as hyperglycemic events. In addition, growth hormone and somatostatins, patients would have as well hyperglycemic event. And as an example of this, many other disease processes could lead to hyperglycemia, and of course diabetes, but the most commonly that we will encounter in other endocrinopathies would be the acromegaly and Cushing syndrome. So there is major interaction for the HPA axis. If you remember, hypothalamus basically regulate vital signs and hunger, thirst, and sleep. Having poor sleep also activates the hypothalamus, releasing glucose levels because the body could go into stress. We mentioned already thyroid gland having dysregulation of the metabolism and hypermetabolism will lead to secretion of ACTH and glucocorticoids, leading to hyperglycemic events. Pancreas, you know that there is alpha cells for glucagon, beta cells for insulin release, as well as the delta cell for somatostatins. Any uncontrolled release or damage by autoimmune diseases of the beta cells will lead to hyperglycemic event, and of course diabetes. Many other disease process, mainly in the adrenal gland, since is the major organ in charge of cortisol and adrenaline. Remember, the cortex will lead to release of ACTH and cortisol, which is your glucocorticoids, and the medulla, the catecholamines, which is adrenaline and adrenaline. And knowing that a fight and flight response being accelerated also will lead to not only changes in blood pressure and water balance and osmolarity, but dysregulation, but as well as hyperglycemia. So having diabetes is not only the elevation of glucose levels, but there, since it belongs to the HPA axis, other hormones could be implicated. Diabetes is already classified as an autoimmune disease. So what happens when there is an increased blood glucose levels, having hyperglycemia? You know that the major function of insulin is to bring the glucose inside the cell, because it's produced by the pancreas and is released when any of stimuli, by ingestion of protein, by ingestion of glucose, is the one that is in charge of degrade or convert carbohydrates into simple sugars and bring that glucose inside the cell. One part to be used for the metabolism and the cell digestion, and the other part to be stored as form of glycogen in the liver in case there is a need for glucose uptake in any emergency situations, such as fasting prolonged times. So because there is hyperglycemia, there is a release of insulin. Insulin will bind to the receptor of the liver, producing entrance of glucose inside the cell, as I said, for the metabolism of majority of the cells. If you remember the Krebs cycle, you will be using carbohydrates first, and if there is an emergency response, you use the glycogen first as well, and you will be producing new sources of glucose by gluconeogenesis and glucolysis before you utilize the proteins and the lipids by proteolysis and lipolysis. When there is hypoglycemia, on the contrary, there is a release of glucagon by the alpha cells. So glucagon will bind to the receptors, and there's activation of adenyl cyclase, which will increase CAMP, which is a second messenger for the production of ATP and energy as part of the metabolism. So this is basically the explanation. Insulin not only allows glucose to enter the cell, also increases the storage in the liver as a form of glycogen. It does promote protein synthesis, as well as reduces the free fatty acid circulation. Functions of other hormones that participate in the axis was briefly already mentioned. The glucagon, basically what does is stimulate breakdown of glucagon by glucose release in situations of hypoglycemia. In addition, somatostatin, which is part of the delta cells in the pancreas, as well as is released at the level of the GI tract. If you remember in patho, inhibits secretions of insulin and glucagon. You have the catecholamines, epinephrine and norepinephrine, released by the adrenal medulla, that regulates glucose metabolism for storage, also does promote glycogenolysis. So this is the reason why if the patient, for example, has pheochromocytoma, or if the body is under stress or any major stress response due to infectious process or any trauma, any disease process that will lead to fight and flight response, patients would have hyperglycemia. But not only that, they will also have high lipids level. Cortisol released by the adrenal cortex is part of the glucocorticoids, and remember the mineralocorticoid will be your aldosterone at the level of the adrenal cortex. Patients with high levels of cortisol also does promote gluconeogenesis, meaning new sources of glucose, therefore having hyperglycemic event. Okay, the growth hormone for patients with acromegaly, for example, they also stimulate cell growth and division, but not only that, it does increases protein synthesis by degrading the glycogen and the proteins and the lipids as new source of glucose. So it does also promote gluconeogenesis as well as glucocorticoids such as cortisol. Thyroxine regulates lipids, protein, and carbohydrates. So every patient that has hyperthyroidism will also have hyperglycemia. So this is the way that patients with diabetes or any patient that is in high stress response or prolonged use of glucocorticoids, or because they do have a disease process such as Cushing syndrome or acromegaly or hyperthyroidism, would lead to hyperglycemia and should be treated the same way as if a patient has diabetes. So this is again another way of explaining the release of insulin and how insulin interacts at the level of different organs as well as glucagon function. So again, what is diabetes? Is basically is a group of diseases that produces hyperglycemia, and basically in patients with diabetes type 1, you would have no insulin release or very, very minimal. So, and diabetes type 2, you would see that is there is a minimal degree of insulin resistance, secretion, and increased glucose production. So the main problem with diabetes type 1 is complete or near total insulin deficiency by an autoimmune destruction of the pancreatic cells, and type 2 is mainly insulin resistance. There's many degrees of insulin resistance, as well as there is impaired insulin secretion and impaired glucose distribution at the level of the cells by an impairment of entrance of glucose inside the cell to be utilized for metabolism. In addition to that, there is a high degree of disturbance of carbohydrates, protein metabolism that would lead to long-term damage and dysfunction of many other organs. If you recall, the signs and symptoms of hyperglycemia basically is this osmotic effect that glucose has on the tissue, producing the polyuria, the polydipsia, polyphagia, having weight loss due to high levels of catabolism, as well as the diplopia or blurred vision. And diabetes type 1, even though diabetes ketoacidosis could be present in type 2, diabetes ketoacidosis is highly prevalent in diabetes type 1. And the problem is that there is no insulin to bring the glucose inside the cell. And if you recall from the Krebs cycle, every time there is no source of carbohydrate, you will be using proteins when the glycogen is exhausted, you will be using lipids. So the patients would have high levels of ammonia, leading to metabolic acidosis, as well as ketone bodies will be released, leading to acidosis as well. And of course, the patients will be severely dehydrated until the cell is damaged, leading to hyperkalemia, many other electrolyte imbalance, major dehydration state until cell death. We'll also discuss later in the second part that diabetes type 2 is at highly at risk of a non-ketotic hyperosmolar state, which if you think about it, in diabetes type 2, there is insulin. There is some degrees of production of insulin, but the major problem is resistance. So even though the insulin is present, the glucose cannot go inside the cell, but at least some or minor degree of glucose is used for the cellular metabolism, and the amount or the degree of degradation of proteins and lipids is less compared to type 1, that there's no insulin at all. So this is the major reason why the cell never goes into high anion gap metabolic acidosis, and it never goes into ketone body production, into ammonia production, and therefore metabolic acidosis would be less. We already spoke about the long-term effects of diabetes, and we will talk briefly regarding retinopathies, nephropathies, leading to renal failure, as well as peripheral neuropathies that patients could have high risk of foot ulcers up to amputation, deposits of calcium, having deformities in the joints, as well as sexual and autoimmune dysfunction. The major risk that these patients would have would be cardiovascular, peripheral vascular diseases, and cerebrovascular diseases. Talking about macrovascular diseases at the level of the brain, patients with diabetes are high risk of CVAs, could include ischemic or hemorrhagic, cognitive impairment as well, is one of the lead factors for coronary artery disease, leading to angina, myocardial infarction, and even heart failure. At the level of the extremities, patients would have peripheral vascular diseases and neuropathies as well, leading to ulcerations, gangrene, and even amputation. At the level of the microvascular level, patients could have from cataracts, glaucoma, up to retinopathies. Kidney, having nephropathies leading to microalbuminuria and renal failure. Now, there are different types of diabetes. There's diabetes type 1, diabetes type 2, diabetes related to gestational, as well as LADA, MODY, and secondary diabetes that we will discuss in the second video. Now, let's talk about metabolic syndrome. If you recall, in pathophysiology, metabolic syndrome is a disease process that leads to insulin resistance. It's also called insulin resistance syndrome, which is characterized by a large waist circumference due to excess of abdominal fat. Patients would have hypertension. They would have abnormal fasting glucose level, as well as dyslipidemia. So there is excess of fat in the abdomen, particularly at the level of the waist and hip ratio. So patients would have waist circumference more than 40 inches in men and more than 35 inches in women. And having this factor is one of the criteria for metabolic syndrome. Now, the only problem is not the fat being accumulated at the level of the abdomen, is that this fat could also be accumulated at the level of the liver and in the muscle as well, leading to insulin resistance, hyperinsulinemia. Glucose metabolism is impaired. patients would have dyslipidemias, patients would have hypertension leading to that. In addition, patients could have serum uric acid level being increased, leading to gout. Um, Not only this, patients could also have levels of fibrinogen being increased and prothrombotic states, leading to DVTs and pulmonary embolies. Um, on my part, metabolic syndrome could lead to obstructive sleep apnea syndrome as well. So diabetes and metabolic syndrome could lead to many other diseases not even related to heart disease and neurological problems. The criteria for metabolic syndrome is projected in your slide. It says waist circumference, again, more or equal than 40 inches in men and more than 35 in women. And this is mainly the central obesity is related to the abdomen. Blood pressure when it's greater than 130 over 85, triglycerides greater or equal to 150, fasting blood sugar levels greater or equal than 100. And of course, this is not an isolated factor because having fasting blood glucose levels at 100 equal to 100 would be a normal value, but if it's combined to high levels of waist circumference and hypertension, of course the patients would have a higher risk. Now, what do you have to assess and who do you have to screen? First, have in mind that hyperglycemia and diabetes has different ways of being classified. You could be completely normal if the glucose tolerance using fasting blood glucose levels is in the range of less than 5.6 millimole per liter or 100 milligrams per deciliter. If the plasma glucose is less than 140 after an oral glucose challenge, or if it's less than 5.6% the glycohemoglobin. That's when you could say that you are a normal person not having diabetes. Now, if you were be classified as pre-diabetic, that means that the fasting blood sugar levels would be between 100 to 125. If there is 2-hour postprandial blood glucose level, it would be between 140 and 199, and the glycohemoglobin will be between 5.7 and 6.4. Now, you are classified as diabetic if your fasting blood glucose levels will be greater than 126 or more than 7.0 millimoles per liter, which is the same, it's in different units of measurement. The 2-hour postprandial would be greater or equal to 200, or if the glycohemoglobin will be greater or equal to 6.5. You have it in your slide later anyways. Now, it's very, very important to screen for diabetes, and screening is recommended. The problem is that many patients are completely asymptomatic and unaware that they have diabetes for years. So who do you screen? And screening is done to every individual that is greater than 45 years of age, and you do this fasting glucose blood glucose level, and if it's abnormal you could do the 2-hour postprandial and the glycohemoglobin every 3 years or even earlier if the patient has metabolic syndrome, or if the patient has any other additional risk factor that could lead to diabetes. So what do you suspect, or what's the criteria for testing a patient with diabetes when the patient is completely asymptomatic? So if the patient has a BMI greater or equal to 25, you should start the screening process. Patients that have physical inactivity, first degree relative with diabetes, of course, it has to be like a combination. It's physical inactivity by itself is not a factor that would lead you to screen the patient for diabetes. But if this is combined with a first degree relative, or if this is combined with obesity, of course, you will do it. High risk ethnicity, for example, Latinos or African Americans. Women who have delivered a macrosomic baby more than 9 pounds, and you would understand why in gestational diabetes. If a patient has hypertension, remember, if the patient now has a BMI greater than 25 and now has hypertension, that's two factors of metabolic syndrome. So you should screen the patient for diabetes. If the patient has hyperlipidemia, so if the triglycerides level are high, even if not greater than 250, but if the patient is greater than 150, which is a factor of metabolic syndrome. Women with polycystic ovarian disease, that's part of the axis. That's another disease process that could lead to diabetes. Patients that do have hemoglobin A1C more than 5.7, which is a factor for pre-diabetes, etc. Or, of course, if patients have history of coronary artery disease. So this is what you need to memorize. This is the criteria for diabetes. So if a patient has hemoglobin A1C greater or equal to 6.5, patient should be tested. Fasting a blood glucose level greater or equal than 126 milligrams per deciliter. 2-hour postprandial glucose level greater or equal to 200 after an oral glucose tolerance test. Or, of course, if the patient has a random blood glucose level without being fasting greater or equal to 200, and the patient has classic signs and symptoms of hyperglycemia, such as polydipsia, polyuria, polyphagia, blurred vision, and weight loss. What is hemoglobin A1C? Hemoglobin A1C is the glycosylate hemoglobin. Is basically a form of hemoglobin that is measured primarily to identify the average of plasma glucose concentration over a prolonged period of time. This is basically over 3 months. So the patients could be fasting, go fasting to your clinical practice, but if they have not have a well control over the past 3 months, the hemoglobin A1C would be altered. So diagnosis of diabetes, remember that if you have a hemoglobin A1C greater than 6.5, greater or equal than 6.5%, is a component of criteria for diabetes. Another one is the glucose tolerance test. Basically, you will be drinking a high load of glucose, and 2 hours later, you will be measuring the blood glucose level, and if the glucose level is 200, patients will be classified as diabetics. So again, criteria: fasting plasma glucose level greater than 126, greater or equal than 126. If the 2 hours postprandial level is greater than 200, or if the hemoglobin A1C is greater or equal than 6.5, or if random blood glucose levels is greater than 200 and the patient has unequivocal signs and symptoms of diabetes. Now, what are factors that could increase the risk for diabetes? The factors could be, remember, the pre-diabetes factor that we already mentioned. So if you have fasting blood glucose level between 100 and 125, that classifies you as pre-diabetic. If the 2-hour postprandial glucose level is between 140 and 199, or if the hemoglobin A1C is between 5.7 and 6.4. Now, what do you have to screen besides that, or what do you have to include in the medical history? The age of the patient, again, even though it's not as relevant now, because patients could have pancreatitis at adult age and develop diabetes type 1, it has been known that for many, many years that the higher degree of onset of diabetes type 1, it would be in the pediatric population or adolescent. If patient has had DKAs in the past, leading, of course, more in diabetes type 1 than 2, um, eating patterns, nutritional status, if the patient has metabolic syndrome, if the patient is obese, diabetes education history, any prior treatment um, related to hyperglycemic events. How is the hemoglobin A1C levels? Have you had any current treatment for hyperglycemia or diabetes that could include hypoglycemic oral medications or insulin? Any adherence or barriers to adherence or to treatment related to hyperglycemia? How's your meal plans? How's your physical activity pattern? Are you ready to be educated, or you're a patient that is non-compliant? Results of the glucose monitoring, DKA frequency. What are the causes of hypoglycemic events? Many patients with hypoglycemia having family history of diabetes, even though they don't have hyperglycemia, they're high risk for diabetes as well. History of diabetes related to complications. Do you have peripheral neuropathy? Do you have any type of sexual abnormality? Any sexual dysfunction should be screened for diabetes as well. Any gastroparesis, any macrovascular process. Have you had a CVA? Have you had an MI? Any psychosocial problem? Any gingivitis? In the physical examination, you should include the weight, of course, as part of the BMI, waist circumference, blood pressure, fundoscopic examination, thyroid. Remember, even though it's related to the pancreas, diabetes is related to the pancreas, it would influence other organs in the axis. Do a skin examination. Patients with diabetes are high risk for acanthosis nigrans, which is basically hyperpigmentation of the skin. Uh, and how are they administered insulin? Do they have atrophia? Do they actually rotate? Do a comprehensive food examination or refer to a podiatrist. Inspect pulses, inspect the skin, palpate the pulses. Um, Patients could have major peripheral neuropathies leading to peripheral arterial disease and claudications, losing reflexes, and also as well as proprioception and vibration that leads to ulcerations and gangrene. How are the values of the hemoglobin A1C? How is fasting lipid profile? Liver function test. As well, you could do uh, albumin creatinine ratio by either spot urine or 24-hour collection to screen for nephropathies and microalbuminuria. That is one of the leading complications of diabetes. Dubulin and creatinine. How's the GFR? Is the patient already in the category of being classified as renal failure? Now, what are the acceptable blood glucose levels? Um, Remember, you are normal if the fasting blood glucose levels is at 100 milligrams per deciliter. You're normal if the 2 hours postprandial level is 140 and the hemoglobin A1C is less than 5.6. Or in other words, still, even though you're high risk for diabetes, if you do before meals or overnight fasting and your blood glucose levels is 70 to 140, that's acceptable even though it's in the range of pre-diabetes. If 1 hour after meal, not 2 hours, 1 hour after meal is no higher than 180, or if it's no higher than 150 and 162 hours postprandial. Now, we already discussed what is diabetes type 1. Remember that it was previously age related, juvenile onset, not anymore. You could have it at any point in your life if you have any disease process such as pancreatitis that will destroy the pancreatic beta cells. It will basically will be an autoimmune disorder. Uh, Mostly strikes in children and young adults. Um, and the major risk factor could be again genetic, HLA related. It could be viral disorder, it could be environmental factor, but the main pathophysiology is an autoimmune destruction of the beta cells, leading to cytotoxic T lymphocytes being released, having a delayed hypersensitivity reaction, um, infiltration of lymphocytes at the level of the beta cells of the pancreas, destroying it. So patients would have hyperglycemia because of that. So as I said, HLA gene related, patients would have an immune response against their own beta cells. That's the main definition of autoimmunity, leading to beta cell destruction and diabetes. As I said before, the initial of the PowerPoint, it could be a viral infection that could also damage beta cells, leading to polyuria, polydipsia, polyphagia, as well as weight loss because of catabolic state. Why will the patient go into weight loss? If they don't have carbohydrate, what do they degrade? Lipids. So lipolysis takes place. That's catabolism. Patient would have no energy, fatigue. Patients would have high risk for infections. They're insulin dependent. They do have familial tendency because it's an HLA related in many patients. And the peak incidence, even though it could be later in life, tends to be between 10 to 15 years. So pediatric patients and adolescents. In addition to that, having polyuria and polydipsia, patients would have nocturnal enuresis. They would have dry skin, deposits of ammonia or ketones if they go into DKA, having skin rashes and pruritus, peripheral neuropathies with burning and tingling sensation in the extremities, with PAD, infectious at any level of the body, most commonly in women, for example, candida, yeast infection, but they could lead to urinary tract infection and many others. The major acute complication for diabetes type 1, even though it could happen in type 2, is diabetes ketoacidosis. But it's not only limited to that. You have, as we already mentioned, many long-term complications, including CAD, hypertension, peripheral neuropathies, nephropathies leading to end-stage renal disease, and even dialysis, having nerve dysfunction, peripheral neuropathies, etc. Now, major complication would be ketoacidosis that we will discuss in a second. Patients could also have hypoglycemic events due to the overdose of insulin or decreased caloric intake. Patients, because of polyuria and polydipsia and the effects of osmosis of hyperglycemia, could lead to dehydration. Infectious process, as we already mentioned, mainly if they're related to the skin, you have gram-positive cocci at that level, leading to staphylococci and streptococci wound infections. This could lead to osteomyelitis, sepsis, and even amputation of the lower extremities. Now, let's talk about DKA. Diabetes ketoacidosis is basically an acute metabolic complication of diabetes that is characterized with hyperglycemia, hyperketonemia, and ketonuria, and metabolic acidosis. Most commonly, as I said, is present in type 1 diabetes, even though it could be present in type 2, but rare. It develops because the insulin levels are insufficient to meet the body basic metabolic requirement. So DKA is happening because when the patient will ingest carbohydrate, there is no insulin to bring the glucose inside the cell. Having this insulin deficiency would lead to the body try to metabolize the proteins into amino acids and lipids into free fatty acids with high levels of glycerol, high levels of free fatty acid, high levels of ketone bodies as part of the uh, um, lipid and protein metabolism, leading to ammonia level being elevated as well. Patients will try to get any new source possible of glucose, leading to gluconeogenesis and glycogenolysis, as well as proteolysis and um, lipolysis. Um, Insulin normally blocks ketogenesis by inhibiting the transport of free fatty acid derivatives into the mitochondria, but ketogenesis proceeds in the absence of insulin. The major keto acids produced by diabetes ketoacidosis or acetoacetic acid and also hydroxybutyric acid, which is not relevant for your study, but those are the main two that leads to high levels of high anion gap metabolic acidosis. Uh, from the protein, acetones derivative from the metabolism will also be present in plasma. The hyperglycemia due to insulin deficiency causes an osmotic diuresis that leads to marked urinary losses of water and electrolytes. Patients would have urinary excretion of ketones, obligates additional losses of sodium and potassium. Now, there is a discrepancy here between hyperkalemia and hypokalemia. Patients would have hyperkalemia in diabetes ketoacidosis because there's cell damage, there's cell death, leading to hyperkalemia, leading to the release of potassium from the cell due to damage. But also, patients could present with hypokalemia due to, as I said, the obligated losses of sodium and potassium by natriuresis. Potassium is also lost in grand quantities due to, again, migration of potassium elsewhere in the extracellular space. But again, the most common presentation would be hyperkalemia due to acidosis from one point from high levels of acetone. Another source of high potassium level will be due to lactic acidosis, due to anaerobic metabolism being accelerated because the cell is going into distress and there's no source of nutrition and energy for the cell. So the pathway passes from aerobic to anaerobic metabolism. In addition, because of ketone bodies being released and metabolic acidosis. In addition, hyperkalemia is relevant as well because of cell damage due to cell death. But don't be surprised that many patients come with hypokalemia instead. So when there is insulin deficiency, there is enhance of lipolysis, there is increase of free fatty acid, there is increase of acetyl coenzyme, not in the mitochondria, but at the level of the cytoplasm. That will lead to acetone bodies being released, as well as lactic acidosis, cell death. When there's glucagon excess, on the contrary, there is not only alteration of the hepatic metabolism, but there is activity of carnitine transferase and also free fatty acid conversion into ketoacidosis that could lead to the same problem. So this is mainly the pathway. When the patients go into hyperglycemia, patients would have polyuria, they would have osmotic diuresis that would lead to high levels of osmolarity. If you recall in pathophysiology, what is osmolarity of or osmolality? Is basically the ratio proportion of electrolyte versus water in plasma. So since the patients would have dehydration because of osmotic diuresis and polyuria, patients would have high levels of osmolality and dehydration. Remember that osmolality is between 285 and 295, or 280 to 290, depending on the book that you read. That leads not only to osmotic diuresis and decreased extracellular fluid volume and dehydration, but that also leads to intracellular dehydration and cell death, and lead to anaerobic metabolism instead. Patients would have decreased glomerular filtration rate. Patients would have loss of electrolytes, sodium, potassium, phosphate, and magnesium, that you would see that will try to replace or replete in the treatment of diabetes ketoacidosis. And because of the above, having a profound dehydration will lead to hypovolemic shock. In addition to having lactic acidosis will lead to high anion gap metabolic acidosis, and there's a vicious cycle that continues. Now, the clinical presentation, patients would have abdominal pain, nausea, vomiting. They would have lethargy and somnolency. They would be hypotensive, tachycardic because of major dehydration. They would be in metabolic acidosis, and as I said, high anion gap metabolic acidosis. And let's talk what is anion gap. Remember that anion gap is basically the difference between measure cations and measure anions, that you could calculate in different ways. Is basically sodium plus potassium minus chloride plus bicarbonate equals 16, or if you don't use potassium as value, is even simpler. The formula is sodium minus chloride plus bicarbonate equals 12. So the anion gap must be less than 12 milliequivalents for the patient to have a normal anion gap. If it's greater than that, patients would have a high anion gap. And we'll discuss in a second the importance of having or knowing if it's normal or high anion gap. So in addition, patients since they're having high anion gap metabolic acidosis, they would try to compensate by having Kussmaul respiration. Remember, the pulmonary compensates the metabolic problem. So patients would have fast respirations and fever, even though it doesn't have to be present. Remember, there's cellular dehydration and acidosis and cell death that could lead to fever, even though it's one of the most significant signs of infectious process in the presence of DKA. Now, in addition, patients, you would see later that patients with DKA as well as the hyperosmolar hyperglycemic non-catatonic coma patients could have acute cerebral edema, which is rare, but it could occur, and mostly in children or adolescents. Patients could have headache and fluctuation of level of consciousness that would lead to respiratory arrest as well. So polyuria, polydipsia, polyphagia, weight loss as basic signs and symptoms of any type of diabetes. But in addition to that, the patient would have abdominal pain, nausea and vomiting, major dehydration, metabolic acidosis that compensates with Kussmaul respiration, and changes in mental status that could go from lethargy up to coma. Now, patients would have alteration of skin turgor because they're dehydrated, and they could be normothermic or hypothermic, but hyperthermia or fever could also be present. So the treatment, the main treatment you would see that is mainly concentrated on fluid replacement and electrolyte correction. Now, how do you differentiate? Let's talk briefly about the non-cathodic hyperosmolar coma, so you would understand this table. It's also a metabolic complication of diabetes, but remember, it's mostly common in diabetes type 2. It is also characterized by hyperglycemia. Patients would also have extreme dehydration. They would have hyperosmolar plasma concentration or increased levels of osmolality. They could also have altered level of consciousness. But what happens here? It's mainly again a complication of type 2, but it does develop after a period of symptomatic hyperglycemia. And the major problem with hyperosmolar non-ketotic diabetes that actually leads to higher degrees of mortality is because the fluid losses and the dehydration are usually more pronounced because not only the patients would have higher levels of glucose level in plasma. Why? Think about it. Patient does have insulin, but there is insulin resistance. So there is higher levels of hyperglycemia in plasma, leading to higher degrees of osmotic gradient and more polyuria. In addition, the patient with hyperglycemic hyperosmolar state is usually older, that has more risk of mental status changes and life-threatening precipitating event that leads to a higher mortality. And this is the reason why they need higher levels of fluid as well. So precipitating factors are exactly the same. It could be acute infection, it could be glucocorticoid exposure, it could be diuretic use, it could be non-compliance to treatment. The serum ketones are not present because the amount of insulin present in most patients with diabetes type 2 are adequate to suppress ketogenesis. Remember that. So because symptoms of acidosis are not present, most patients endure a significant longer period of osmotic dehydration before they seek medical health or they go to the hospital or they go to the clinic. So this is one of the reasons why plasma glucose levels are greater than 600 milligrams per deciliter, and this is the reason why osmolality is greater than 320, which are typically much higher than that. I have seen that in practice. Signs and symptoms are more or less the same, but of course the patients would not have ketonemia and ketonuria. They could present with altered mental status, more confusion, more disorientation. They tend to be elderly, even though again type 2 could occur in pediatric patients. They have an extreme dehydration state. They come into pre-renal renal failure, hyperglycemia, hyperosmolality. In contrast to DKA, focal or generalized seizures could occur. So to compare, for DKA, I know there is mild, moderate, severe, but for DKA, the glucose tend to be less than 600. Never reach that. And in HHS, tend to be more than 600. The arterial pH, since there is more ketosis, more lactic acidosis, more cell death, DKA would have high degree of metabolic acidosis. So if you look at the pH, is between 7 to 7.20. In contrary, because there is no cell death or the metabolism is better because there's insulin, even though it's resistance, patients with HHS, since they don't go to ketosis, no acetones, no lactic acidosis, the pH tend to be greater than 7.30. Bicarbonate will be the same. If you look at the levels of bicarbonate in DKA is severely decreased, sometimes be less than 10, and it's more than 15 in HHS. Do you see ketone bodies in serum and urine in DKA? Yes. It could be present in HHS, but it's rare. Serum osmolality. Patients, of course, are dehydrated in DKA. That's the reason why it's variable. Depending if it's mild to severe, that's the high or low degree of dehydration that the patients will come in. But for sure, because again, patients with HHS endure significant longer periods of osmotic dehydration because they're asymptomatic. They will come with a higher degree of dehydration greater than 320 osmolality, and also because there is high glucose levels leading to more osmotic gradient. An ion gap, it will be more than 12, so it will be high anion gap metabolic acidosis in DKA, and less than 12 or normal anion gap metabolic acidosis in HHS. And alteration of consciousness actually does vary. Of course, the patient with HHS will come with higher degrees of that. So the majority of the labs, patients will come in with hyperglycemia, of course, depending on the type of if it's DKA between HHS. If it's DKA, patient would come with what? Hyperkalemia, leukocytosis, hyperosmolality. You will see ketone bodies in plasma and in urine as well, and lipids level will be elevated. Now, management. The management of DKA is complicated as well as HHS, but it must be concentrated on fluid correction, glucose correction, and electrolyte imbalance correction. The rest actually corrects by itself. So let's discuss that. First, if the patient is vomiting or has altered mental status, you can't give anything but IB, but in addition to that, you have to avoid aspiration. So you will first, because of the abdominal pain, nausea, and vomiting is one of the symptoms of DKA, you would put an NG tube, right? Patient will be an MPO. You put the patient on an NG tube. In addition, you would protect the airway. If the patient is in respiratory failure, you intubate the patient. If the patient is hypo-oxygenating, you put the patient on oxygen. Try to protect the airway, administer oxygen. Now, the main stem of treatment for both is replacement of fluid. And how you would do that? Be very, very careful. I know there is a major deficit of water in both, more in HHS than in DKA, but you have to do it slowly because rapid correction of fluid could lead to not only cardiovascular problems, including pulmonary edema, but as well it could lead to cerebral edema, which is one of the major complications for rapid fluid replacement. Okay, so yes, you would see that the deficit would be higher in HHS, up to even 10 liters they need over the first 3 days periods of treatment, less than in DKA, but you have to do it slowly. Okay, so you would basically first start with isotonic fluid, and that will be normal saline. You will be giving at least 1 liter in the first hour, and then after that 500 mLs per hour. That's what the protocol says in many hospitals and in your guideline. Okay, so fluid replacement over 12 to 24 hours. So again, first isotonic saline infusion, normal saline. It's as quickly as possible, but not as you're not going to replace 3 liters, which normally the DKA has a fluid deficit between 3 to 5 liters. You're not going to replace those 5 liters in the first day. Okay, so try to at least give a bolus, okay, of 1 liter in the first hour, and then you could continue 500 mLs per hour because of the major complications that could lead to that. So you would do that until the patient is hemodynamically stable, or the patient has improvement of urinary output. If the patient continues to be hypovolemic, but the patient is not in shock, and how do you determine that? Clinical data. Look at the skin turgor. Look at the BUN and creatinine. If the BUN is elevated, if the creatinine is elevated, and the patient is having still renal failure, that's an indication of hypovolemia. But without shock or heart failure, overt heart failure, or acute decompensated heart failure. So you could continue, instead of a 500 mLs per hour, you could do it between 15 to 20 mLs per hour. What I'm trying to tell you here is that if the patient has signs and symptoms of volume overload, because again, you could have pulmonary edema, you could have anasarca, having third space edema, and being completely dehydrated in plasma. So if you do have any sign or symptom of volume overload, even though your osmolality is high, even though your urinary creatinine is high, you have to continue slowly to avoid more pulmonary edema and cerebral edema. So usually normal saline is given the first 1 to 3 liters. So your deficit would be 3 to 5 liters. And the formula that I recommend, that is also in your book, is at least 1 liter in the first hour, then 500 mLs per hour. Now, if glucose are greater than 500 milligrams per deciliter, instead of using normal saline, you could use half normal saline after the first hour, as water deficit exceeds sodium loss. When the glucose level fall less than 250, then you will be changing to D5 half normal saline to prevent hypoglycemia. Okay? So, half normal saline, 250 to 500 mLs per hour, also is useful to avoid hyperchloremia induced by normal saline. Other institutions, instead of starting from the beginning with normal saline, they will start with lactate arranger to avoid hyperchloremia. Now, the problem with lactate arranger is the lactate component that could lead to more metabolic acidosis. So I wouldn't agree 100% through that formula. I would start normal saline first, and as soon as the sodium is corrected, then I would switch to half normal saline, and I would add dextrose to it when the glucose level reaches between 200 to 250, depending on the book that you're reading. Now, again, so repeating, when the patient is, you do the initial bolus of normal saline, right? 1 liter in the first hour, and then you continue 500 mLs per hour unless the patient is volume overloaded. When the patient is hemodynamically stable and the patient has urine output adequate, you could switch to half normal saline. And doing that, remember, it will improve the chloride component of metabolic acidosis. In addition to that, we need to treat the glucose part. So let me switch to the insulin and then we'll go back. So the most important part, insulin. The second most important part, besides the electrolyte that sometimes they correct by themselves, is insulin, because what's the major problem? The major problem is hyperglycemia that is leading to all this. So what you have to do is give 0.1 units per kilo per hour of regular insulin. So first you're going to give a bolus, and the bolus will be based on 0.1 units per kilo, followed by 0.1 units per kilo per hour. If the glucose does not fall by at least 10% after the first hour, you could either repeat the bolus or you could double the dosage of the 0.1 unit per kilo per hour by 2 folds. Do you understand? So either increase by 10%, double it, or repeat the bolus. Okay? So first bolus, 0.1 unit per kilo. Second, continuous infusion of 0.1 units per kilo per hour. It could be also 0.14 units per kilo per hour of regular insulin if you do not want a bolus. If the serum glucose does not fall by 10% after the first hour, or which is the same, by 50 to 70 milligrams per deciliter in the first hour, which is optimal, okay, the dose must be doubled, or you could repeat the bolus. If the serum glucose level decreases by 100 milligrams per deciliter in the first hour, then what you would do is decrease the drip by 50%. You must memorize this. Okay, so now let's go back and we'll do electrolyte replacement. Now, you should never treat the hyperglycemia. Hyperglycemia will be corrected initially by itself. Why? Because by giving insulin, remember that insulin brings potassium inside the cell, so do not give glucose, do not give chiaxylate, you don't have to give calcium gluconate unless the patient has EKG changes. And also, when the acidosis is getting corrected, the potassium also will be corrected. When there's fluid shift by infusion of normal saline or half normal saline, whatever you start with, that hyperkalemia as well will be corrected. So hyperkalemia doesn't have to be corrected. Now, sometimes there is significant potassium loss. In order, and you must remember this, in order to replace potassium, the patient should have an adequate urine output because the only way of potassium excretion would be through the kidney. Now, check the BMP, check ABGs, check magnesium and phosphate levels. Correct the sodium if it's necessary. Okay, so for potassium stores, you could give potassium phosphate or potassium acetate to avoid giving potassium chloride, because remember, we need to avoid hyperchloremic metabolic acidosis, and try to replace potassium to have a goal of more than 3.5 milliequivalents per liter. Now, you have to monitor hourly the urine output. You have to also monitor laboratory values. In order to replace or correct hyponatremia, you will learn this next semester with me. Basically is you have to calculate the deficit of sodium, which is the measured sodium plus 1.6 divided by 100. We'll learn that next semester. It's not going to be tested now. Now again, potassium. Do not correct initially the hyperkalemia. Okay, so when the potassium is greater than 5.5, do not put potassium in the IV fluid. When the potassium is 4 to 5.4, you could add 20 milliequivalents to it. When it's 3 to 3.9, the same, or when it's less than 3, you have to add 60. If the potassium is less than 3.3, do not give insulin until the serum potassium is supplemented. Why? The patient could be in diabetes ketoacidosis, but if the patient comes with hypokalemia and there's adequate urine output, you must replace the potassium first before you give the first bolus or the continuous infusion of insulin, because otherwise insulin will bring more potassium inside the cell, and now it's not going to be 3.3 potassium, it's going to be 2 or 1, and the patient will go into arrest. Bicarbonate. It's actually, even though the patient could come into bicarbonate deficit, It's not necessarily to replace the bicarbonate, because replacing it could lead to cardiac dysfunction, more anaerobic metabolism, and more hypokalemia and more cerebral edema. So do not replace bicarbonate unless the pH is less than 7. So only if the pH is less than 7, or the serum bicarbonate is 5 to 10, or the acidosis itself induce cardiac or respiratory arrest, or of course if there is severe hyperkalemia. The bicarbonate will be will be corrected by itself when you give insulin, when the acidosis is corrected, when there is fluid challenge being given. Magnesium and phosphate as well is usually not necessary. Okay, so if the serum phosphate is less than 0.32 millimole per liters or 1 milligram per deciliter, then you could consider giving phosphate supplements and as well as calcium. We talked about the insulin treatment already. Now you must continue to check glucose. The goal is to decrease the blood glucose level between 50 to 75 deciliters per hour. So you have to do a Q1 hour blood sugar levels. Of course, AccuCheck. Okay, if there are 3 consecutive that are stable, then you could switch to 2 hours check. Remember, you must add dextrose to fluid when the blood glucose levels is less than 200 to 250. You must maintain blood glucose level between 150 to 200 to avoid high anion gap acidosis. Now, after that, when there is correction of the glucose, when there is no acidosis, you could continue monitoring the blood glucose level and the insulin rate. Of course, if you are on the IV drip, you could decrease the IV drip of insulin to 0.05 instead of 0.1 units per kilo per hour. You could start adding long-acting insulin, but remember, do not discontinue the drip because the long-acting insulin must take place. So start sub-Q insulin when the anion gap closes or is normal, when the serum bicarbonate increases to more than 50 milliequivalents, when the patient can eat, when the mental status improve. Stop the insulin drip when you start either Lispro or long-acting, but don't stop it right away. You must ensure that the blood glucose levels are within normal limits for at least an hour. And of course, if the patient is eating. Now, continue to laboratory management. You must continue for diabetes type 1 and as well as diabetes ketoacidosis, the hemoglobin A1C, the lipids, the liver profile, the albumin micro spot, and also ratio of creatinine as well as 24-hour urine. You could do beyond creatinine, you could do TSH, you could do C-peptide. What's C-peptide? It's basically how much of insulin or their own natural insulin is released by a person, even if the person received insulin exogenous. So it's a pro-insulin mediator that is present in patients with type 1 diabetes, as well as insulinomas and many other tumors. You could do a CBC, you could do a urinalysis, you could do a chest x-ray, white chest x-ray to see if there is an infection, if there is pulmonary edema, for example. CBC will tell you if the patient would have infectious process. In addition, if the patient has any type of hemoconcentration, urinalysis, either for the spot of microalbumin, creatinine ratio, or also if the patient has urinary tract infection, TSH to see if hyperthyroidism has led to this event or if diabetes has affected the thyroid as well. Liver profile. Remember, these patients would go into liver failure as well, if liver failure could induce to diabetes, or if the shock process have induced a liver shock. Hyperlipidemia and hemoglobin A1C, for the how well controlled is this patient over the past 3 months. So these are the risk factors that we already went through. And the management as well, not only of diabetes, but as to prevent major macro microvascular complication. You must reduce the hemoglobin A1C by 1%. In newly diagnosed, you should manage a lipid by the ATP3 guideline that it was already posted in your Canvas site. Even though there's a glance here in this presentation, reduced blood pressure by 5 millimeters of mercury systolic or diastolic by 2 in newly diagnosed. Remember that your main target level for dyslipidemia is your LDL. And if you do not have CAD or CAD equivalent, you could be less than 100, but if you do have a stroke or you have cardiovascular diseases or many compelling indications related to cardiovascular disease, you must be less than 70. Even though you would start lifestyle modification first, if this does not work, then you must start statins unless contraindicated. And the other exception that we already went through in the ATP3 guideline is to control hypertriglyceridemia if they're greater than 500, because it could lead to pancreatitis. Okay? So types of insulin, we have the rapid acting, which mainly the onset is 5 minutes and peaks in the first hour. We do have the short acting, which is the regular insulin. It takes about 30 to 45 minutes to work, and it peaks in 3 to 4 hours. There's an intermediate acting and long acting. Now, there is the conventional, intensive, and other ways to administer insulin. The conventional therapy, basically there's a calculation. You will split the dose of two-thirds of NPH and one-third of regular insulin in the morning, and one-half of NPH and one-half of regular at night. Basically what you would do is, the rule of thumb is to begin with 0.5 units per kilo per day. So you're going to take the kilograms of the patient. For example, if it's 70 kilograms, you would do 0.5 times the kilograms, and the ending result, you're going to give two-thirds in the morning, and the remaining is one-third in the evening. And from that, you're going to give two-thirds of NPH and one-third of regular in the morning, and in the evening you're going to do half of NPH and half of regular in the evening. So again, the first is to do 0.5 times kilograms per day. The amount, you're going to divide two-thirds in the morning and one-third in the evening. From the two-thirds in the morning is going to be two-thirds of NPH and one-third of regular. From the amount of one-third in the evening, you're going to do half of NPH and half of regular. There's another method, which is the intensive therapy, which you would reduce or omit the night dose of insulin and add a portion at bedtime. And again, this is the main calculation. So you're going to do 0.5 per kilograms per day. the amount, the total number here, you're going to do 2/3 in the morning, and from that 2/3 in the morning is going to be 2/3 of NPH and 1/3 of regular, and from this 1/3 in the evening, you're going to take half of NPH and half of regular. It's mathematical equation. So this is the end of the first presentation, and we'll do the second half for diabetes type 2.